Well, today we have Adriaan Louw, who's joining us to give us some updates on some of the activities and research that he's involved with. And I would love for you to just kind of take it away, Adriaan, and let us know what you're up to.
Oh, wow. Well, thank you. Thanks for having me. We do so many things. As I'm sitting here, I'm thinking, okay, what are we working on? The easy way to explain this to you, to your listeners, would be that we're working in different fields. One is we're still working on pain science, on people with chronic pain. How do we explain pain to them so they really can understand it? So there's still this clinical version, if you will. The areas we've been expanding a lot in lately is in surgery, in preoperative, to prepare people for surgery and the pain experience. We have a big initiative right now with the Department of Defense and the VA with our soldiers and our veterans, which really struggle with pain for that matter. Another initiative which I'm super excited about is we're doing a middle school program. We've done it now in 9 states where we teach middle school kids about pain as a way to, for a lack of a better term, to inoculate them against chronic pain. The idea would be that we cannot prevent pain, but we can prevent chronicity. So when little Johnny falls in the playground, he can jump up and go, "I'm going to be okay. The guy with the funny accent explained it to me." We're doing stuff right now, also intriguingly, in acute pain, where we have shown that if you can do this preventatively or preemptively, for that matter, maybe we can make people's lives better when they do experience pain. So we're doing a lot of things. We're doing virtual reality for pain stuff. We're playing in so many ideas right now, but those are probably the biggest areas we're working on for that matter. We got our pain conference coming up. We teach constantly all over the country, all over the world in different places. So yeah, we're constantly busy.
Awesome. Well, as far as the children, that brought up an interesting point. Are there people that reach out to you, or do you kind of select those communities that you go to, or how does that happen?
Yeah, so Melissa, we started with research, and it's still a research project, by the way. This is a thing we've been toying for years with. And so we went to Wisconsin. We gathered 147 middle school kids, and the red tape is very high because you got to get parent consent and the school board. So it takes a little bit of work, but we got it approved. We trained 147 middle school kids about pain, the way we currently understand it, how pain really works. And lo and behold, the kids had a higher increase in pain knowledge than any group of people we've ever measured, including healthcare providers. And so we were like, wow, this is really cool. But what does it do? And so we're running a trial right now where kids are getting traditional education in school about injuries, sprains, strains, fractures, kind of the gooey stuff that makes you, ooh, that's kind of bad. And by the way, it's just, they're already taught it. We're not designing it specifically to make them scared. And then our program, and then these kids are being tracked throughout their school career for school attendance, PE attendance, sports attendance, going to the doctor, medicine, those kinds of things. And it's very intriguing. The preliminary data shows the kids that learn more about pain, how pain really works, the way you and I understand the neuroscience of pain, they are way less afraid of pain. They're okay with the idea of pain as a normal thing. Versus the other kids who basically see pain as the enemy. It's the worst thing ever, which you and I know pain's a normal experience, right? It's what you do about it that's critical. And so our preliminary data, it's in 9 states we're testing it. It's a massive database of students. So we have actually seeked out schools. So we have trained some clinicians to do it. They go to schools and train them. Once we show the program work, we build a video version or an animated version of it. So we're testing formats of it, what kids can learn, what, etc., which is kind of what we're playing with. In one study, we're teaching parents and kids. The other group, only the kids get taught. So we're playing with all kinds of variables for that matter. But it's very intriguing. And our goal is ultimately, if this thing works the way we think it does, we want to make this 100% fully free, available to any healthcare provider to take it to their community. Basically, at this point, looking for funding and looking for a grant. Maybe some huge benefactor, will come along and say, hey, great project, we're going to give you money, build this, and then we can take it. There's no intent here to make money out of it, but to make society better. And so so right now we're seeking them, but a lot of clinicians that hear about it call me and say, Adriaan, I'd love to go to my local high school or my local middle school. My kid is in school. Can I do it? So we're doing stuff like that, no doubt about it, but we're still testing. So we're a little bit leery handing it out just because it's still in test mode for as part of our research.
Gotcha. Mm-hmm. Now, it's interesting, is it what you're testing is kind of the language you're using or the types of topics? What's the most tested?
Yeah, so we're testing basically what age group they can take it on. Most learning theory says kids around sixth grade can take it on. So we went one grade lower, fifth grade, they can get it. We're launching a study where we're going to fourth grade. We want to see where is the cutoff point. So that's one. We're looking at basically delivery methods. So we recently got done with another version where some kids get it one-on-one with a healthcare provider in the room, like you would have to take time off to go to your school and, hey kids, good morning, rah, rah, rah. Or we provide them an animated video. And so we're testing it because for scalability, we have to create something that's easy. And so this video animation version we've shown is just as effective actually as live, not as good, but statistically the same. So we're looking at delivery formats, we're looking at durations. Again, class periods are not that long, so you cannot do a 3-hour version. And there's a lot of, right now in the pain world, a lot of ideas about teaching people about pain. Our group is probably the group that says less is better. There's almost this idea that if somebody doesn't understand it, you got to do more. Our data and all our research shows us maybe we're giving them too much. You need to kind of take a bite and chew on it for a few days and then bite again, chew on it. So more isn't better. Our data says maybe less, but more concise. So, but there's little variables we're working with. So,
Would you say that giving them a little bit at a time is more, I guess it allows that more effective approach where you kind of layer it or roll it into their experience so it kind of makes sense, and then they can roll in more information and start believing in it more? Or
more than likely. I mean, I think in the old days we had the fire hose approach, right? This is what I know about pain. Open up wide, here we go. And we did it 20 years ago. That's the way I was trained. And we found that many people were overwhelmed. Remember, pain is a very personal experience, very emotional. We now know that pain gets processed on three very distinct levels. We have almost the reflexive, nociceptive versions of it, then go to cognitive, you think more, but once it gets to the emotional tracks where the brain chronicify over time with pain, it gets real and it gets very overwhelming. So the idea is that the more complex pain gets, the smaller bite sizes we give them because they have to deal with more emotions. And it's real, it's very real, where people have to take a little bite and chew on it and think. And then, like you said, they relayer it over time. Yep.
right. And it's great because it seems like, when you can reach to the children, when they haven't really, if they haven't experienced pain and haven't become just this emotional overwhelm with the experience itself, and they kind of know about it ahead of time, they might be able to recognize it. But the ripple effect that they might use with their parents seems to be of a huge benefit. Is that kind of an indirect way to reach out to the adults?
Maybe. I mean, I don't know. I don't know. It's hard. I mean, do kids really influence parents or vice versa? The data right now says parents influence kids, which is intriguing. I mean, it would be so cool if a kid actually has beautiful behaviors about pain, and mom or dad who are catastrophizers or fear avoidant look at their little kid and go, wow, they're really awesome, and I should do more of that. That'd be cool. I'm not sure I'm buying it because I've seen the opposite usually, but I don't know. That'd be cool. I mean, I as a parent, I mean, for me, it's amazing watching my kids. My son is enormously patient, and I am Mr. Go, go, go all the time. So I am actually learning from my son. So it could be the other way around. I don't know.
I guess it depends on the dynamics, or maybe it's just my wishful thinking. Well, speaking of ripple effects and how powerful education is, can you talk about a little bit about this conference coming up and who it's for?
Yeah, we've been hosting a conference for the last 7 years, and it started quite kind of as a groupie thing, like, hey, we all like pain, let's get together and learn. And then we started putting speakers, etc., together. It was called the Clinical Conference. It was in Minneapolis for years, and it started growing and growing. And then we kind of worked out of our space. We now moved it to Denver. They renamed it the Align Conference. It's March 8 to 10 in Denver. You're joining us there. We're super excited about it. The focus next year is moving pain. And we're kind of playing on the idea that movement and pain goes together, right? Movement is probably one of the biggest painkillers on planet Earth, period. But then there's also the pain movement, moving pain in America, moving that needle one step further. You and I know with the opioid epidemic, with so many medications, so many scans, all those things, we got to move it. Even with the school program, right? Moving society. So we have great speakers. We have You know, Joe Nice from Belgium is one of the world leading experts on movement, memories in the brain and pain. We got Greg Lehman, a great chiropractor, PT out of Canada, that deals with kind of the old models we were taught that, hey, we got to deconstruct those. Pierre Cote has done some amazing stuff in whiplash in Canada, where they've changed the no-fault laws about whiplash. So we're working all around movement and pain, and we're looking forward to a great conference and just getting together, learning from each other. The nice thing is, it's not only platforms where you and I would speak, but there are lab sessions where people can come to smaller classes and learn from basically experts from all over the United States and internationally for this conference.
Awesome. Well, as far as the idea of education is medicine, I know that a lot of us say that. Why do you feel education is medicine?
You know, Melissa, through the history of mankind, whenever we faced an epidemic, the most effective treatment has been mass education. If you think about things like West Nile virus, you think about H1N1 virus, you talk about Ebola, etc., smoking, whatever. Mass education has been, the WHO have told us pain is going to be its biggest problem they'll face in the history of mankind. Now we deal with Ebola, etc., which is very serious stuff, but overall, if you look at it, so there has to be this mass education, and that's fine. And we can go on TV and create commercials, but they're still the real person. So we start one at a time. And we have a plethora of research right now that shows if I teach you how pain works and you get it, as my mentor David Butler says, in the marrow of your bones, you go, I got it. The brain scans show us the brain beautifully calms down. Benedetti's research shows us that when you go from catastrophizing to less catastrophization, the brain turns on your opioids, your cannabinoids, etc. So there's real physiological effects that we can measure that occurs with good solid education, which is wrapped into empathy and compassion. Remember, honesty without compassion is cruelty. Sometimes you have clinicians that are very smart. This is how your back works. This is how pain works. But there's no empathy. There's no compassion. So it's not as simple as just education. It's education wrapped in care, compassion. I really care about you. I would like to help you. So, but anyway, without referring there, the neuroscience evidence is mind-blowing how education can alter the brain, your endogenous mechanisms, your nervous system sensitization, etc. So it's definitely education is medicine, no doubt about it.
Right. And tying this whole idea about moving pain, you think about how education is going to affect your sometimes test and potentially change your beliefs, which obviously if you're going to move with pain, you have to have sometimes a different belief system in order for you to activate the thought that it's okay to move. So tying that education with moving, to me, it's all kind of comes together in one package in order to actually make progress. Would you agree?
Absolutely. I mean, I know some of the best clinicians in the world that are movements experts, but they never explain to them what's going on. And you and I know today that fear and fear avoidance is one of the biggest predictors of chronic pain. So when you move but you hurt and you don't understand it, you have increased fear, which means it's a self-fulfilling prophecy. You're going to get worse. On the flip side, we teach you how pain really works and you reconstruct it going. So movement is okay. Pain is okay. So we teach patients new mantra, sore but safe. Hurt doesn't equal harm. So we often will take a patient out to the gym area. We'll pull on a rubber band and say, can you feel your arm? Yes, I can. What's it telling you? You're pulling on a rubber band. Just because you're feeling your arm doesn't mean there's something wrong with it. This is a classic thing where we confuse nociception with pain. But our patients are so wired, so sensitized, they don't know what to think. And just to make sure they protect themselves. So those two are critical. And I don't mean in disrespect here today, but I mean, I work with a lot of psychologists and mental health providers. And one of the advantages of especially rehabilitation is the fact that I can teach you right now in a treatment room. I can walk you out to the gym and do the actual movement with you. My psychology colleagues can teach you about stuff and then tell you, go walk. But not actually be with you. And I'm not having a go at them. They know I care deeply about them. They do stuff amazing with patients. But that combination, movement plus education, is currently probably the gold standard in about any pain approach. If you look at the Cochrane reviews for fibromyalgia, chronic fatigue syndrome, there's always a cognitive component and there's a movement component. And then my physicians like you prescribe things to calm the system down, your anticonvulsants, your membrane stabilizers, your antidepressants, etc. But those two are always tied together. They cannot stand apart.
Right. I will speak from a physician standpoint. I think there's obviously, I believe there's way more of an emphasis on the things that we prescribe, because I don't, when it comes to whether you're a patient who has pain and trying to believe that moving and certain things will help them, it's hard to believe it until you experience it. And I really believe that physicians themselves may not value the movement and the education as much as they would if they had been trained or experienced it themselves. I don't know if you agree with that, but I do feel like there are more things being given to calm the nervous system down, because I don't think the belief and conviction from physicians is as high as it should be.
Yeah, I mean, bottom line is my best referral sources are physicians that were my patients. When they came in the clinic and saw what we did and how we do what we do, go, wow, that really helped me. The bottom line is, I mean, if you experience it, right, and it changes your life, it definitely impacts you. So if you were in pain, you came to our clinic, we worked with you, and you left going, wow, my life's better because of what they did, you believe in it, right? Fair enough. We all have our beliefs. But it brings up an issue for me, and that is the education part. Do we educate providers enough? Unfortunately, if I put my PT hat on, we get very little space on medical councils when we speak. I speak at a lot of medical conferences, by the way, but it's a classic thing. You get your 20 minutes and you're done. Not that it's okay. We're very happy, but the cool thing is the future of healthcare is going to be interdisciplinary, multidisciplinary. So I see more collaboration. So I see more positive. The newer physicians are coming out. They're more embracing of things like mindfulness, meditation, movement, exercise. I hate to almost put it this way just because I've been around that long, but it's kind of like the old guys dying out. And it's this young group of physicians coming in, the young group of physician assistants, nurse practitioners that are more embracing of things like yoga, Tai Chi, things that we all know has an effect. There's good research behind it. So maybe I'm seeing a couple a little more half full, but I'm telling my therapists every day, you need to go talk to your physicians and let them understand who you are and what you can offer. But yeah, if they could come in for treatment, that's better. So maybe, when they talk to a doctor, kick them in the knee so they have a little bit of knee pain and they have to come to therapy, and we can make them a little bit believers that way.
Yeah, it's the unfortunate aspect that sometimes you have to go through it to truly believe it.
That's true.
Well, speaking of education, I wanted to share this book that you have put out. I'm hoping that you can see that. But the Pain Neuroscience Education, has a lot of pictures and good organization of trying to understand the nervous system. Do you mind just giving a little brief idea of how this is organized and who it's for?
Yeah, we wrote the first version in 2013, and it was time for an update. Unfortunately, there's so much cool stuff. The book doubled in size. There are basically 6 chapters, if you will, or 6 components. The first one talks about the idea that how our cognitions are tied to our pain. I know this seems very mundane and boring for, say, psychologists or psychiatrists, but for me as a physical therapist for a year, we really didn't care what you think. If you got a bad joint, let's work on the joint and get you better. So for us to almost teach clinicians that what patients think and believe drive their pain, that's a critical part. So that's the first part. Then we go through kind of this evolution, this idea of teaching people about pain. So we talk about how did it start, how we tested it, some of the pioneers, Louis Gifford, Lorimer Moseley, David Butler, how we came to be where we are. We also do spend quite a bit of time on the evidence of it. There's really good evidence of the numbers needed to treat, etc., in favor of this. We then probably spend, Melissa, probably a third of the book is on the update on the neuroscience of pain. There are so many things about pain that we were taught in school that is outdated, maybe even wrong. I mean, gait control, 1965, Melzack and Wall, that we're talking about something 53 years ago, and it's still the #1 thing taught in PT school about pain. I mean, Melzack has been quoted literally by saying, for the love of God, move on. There's more to pain than just gait control. So we teach more about the neuroscience of how pain really works. The 4th chapter, we have 46 different pain stories / metaphors that clinicians can learn you know, how to explain central sensitization to a patient, how to explain spreading pain, why when it's cold you feel your shoulder more than other days. So we've used all these clinical stories we've built. We do then spend a little time, unfortunately, the reality of how do we do it in a real clinic, because we all have deadlines, we have productivity needs, we have to bill for it. So there's a little bit of that about how to build it in a thriving practice. And then for me, the best part is the last part, and that is where we show there's 22 things currently in rehabilitation that we can do that turns on the brain's endogenous system non-pharmacologically. So we go through sleep, nutrition, we go through exercise, we go through goal setting, pacing, rate exposure, the list goes on and on. So this was designed for healthcare providers interested in kind of a clinical version of helping people in pain. This isn't your heavy neuroscience 101 textbook from Melzack and Wall, but it's a good clinical guide for people to how to help people in pain.
That's great. Well, because you're a generous man, I definitely want to open up the opportunity for people to have the opportunity to win a book and signed by you, Adriaan Louw. and and I would love for those that are watching that made it this far in the video to go ahead and share that you're interested in the book. And also if you can either send a question that maybe you're curious about that's related to this conversation, or anything that you would like to have spoken about in the future so that we can serve everyone better. I would love to have you add your name to the comments below. So I wanted to thank you again, Adriaan, for allowing me to interview you on some updates that are going on. And we'll plan on doing a couple more over the next couple months and maybe address some of the questions or interests that people have in the comments.
Absolutely. And again, thank you for all you do for our patients in pain.
Thank you so much.